Yes, ma'am, you can start.
Okay, yeah. Good evening, everybody. I don't know whosoever are there, but this is Dr. Mrudalika Sharma. I am a gynecologist, and here I am discussing a bit of mechanism of labor as a part of Neet PG schedule. So before we start on mechanism of labor, we need to understand some basic understanding of pelvic anatomy. You can say the maternal pelvis and the fetal skull to some extent, so that we can understand the better diameters and better the presentation and position of the fetal skull while it is passing through the pelvis. So here is a maternal pelvis. In short, it's just showing the bony structure like tuberosity, sacrum in the posterior part, pelvic symphysis in the anterior, and the iliac bone on the lateral side. But more importantly, we need to understand the border of pelvic inlet. Basically, pelvic is divided into three parts. The pelvis inlet, when the fetal skull enters in it, then the pelvic cavity, that is called the mid pelvis, and then the pelvic outlet, through which the bony skull of the fetus is passes out. So they are the borders of pelvic inlet. Posteriorly, it is bound by the sacral promontory. Laterally, we have iliopectineal line, as you can see, this purple border. And then anteriorly, we have the pelvic symphysis. The pelvic is basically the inlet of pelvis. And it is bounded by the promontory of sacrum, transversed by the upper margin of pelvic bone, the iliopectineal line, and the L of sacrum. The transfer diameter in this plane is around 11 centimeter and sometimes 11.5, depending on the stretching of the pelvis. And the AP diameter is 11. So you can see there the largest diameter is transverse diameter, that is 13.5. So whenever the fetal skull enters in it, it usually occupies the transverse diameter at the point of entry. It has to be transverse diameter. Now there comes the pelvic mid cavity. It's an area bounded in front by the symphysis pubis and posteriorly by the second and third section of sacrum. That is the sacral bone, transversed by the pubic bone, the fascia, and the inner aspect of ischial bone and spine. The cavity is almost round and having both the diameters of the same around 12 centimeters. It's the AP and transfer diameter. Both are same here. This is 12 centimeter. Then comes the border of the pelvic outlet. It is basically posterior the tip of coccyx. Laterally there is ischial tuberosity and anteriorly it is pubic arch. It's basically a diamond shaped pelvic outlet and having you can see a bit of outline here. This is the upper cavity, then the inlet, then there's the middle cavity that I just described as the mid pelvis, and then the outlet. Now the pelvic dimension of the importance. As I discussed, pelvic inlet transverse is 13 centimeter, AP is 11 centimeter, mid pelvis is 12 and 12, and pelvic outlet is 11 at transverse and 13 in the AP diameter. So whenever the fetal skull goes out of the cavity, it has to occupy the AP diameter. And where the importance of internal rotation comes, that I'm going to explain later. Now, since the transverse diameter is greater than the EP diameter, as I already told you, the pelvic vertex circumference of the fetal head, it descends in the transverse position. However, when it gets to the pelvic outlet, the fetal head has to rotate from a transverse position to an anterior-posterior position, and the AP diameter is greater than the transverse diameter. Now, here are the three important points to discuss. There are the four kinds of pelvic before I say this point: the gynecoid, android, anthropoid, and platyploid. The gynecoid pelvis is the most favorable for labor and most common. The android pelvis is set to be disposed to a deep transfer arrest, basically a stoppage of the labor. And anthropoid pelvis, it encourages an occipito-posterior position of the fetal skull, and a difficult labor has to go through then. And the platyploid pelvis is also associated with an increased risk of obstetric labor. So when the patient is, I mean, a female having this kind of pelvis, so you just can't see, you just can't tell the patient having this kind of pelvis. It's difficult, but it's an assumption when these pelvis are there, it's going to be a difficult labor. And most common and the most easy pelvis for the labor to go on is the gynecoid pelvis. So now, before we start the discussion of the mechanism of labor, we should describe the following terms in relation with the fetal skull. The most important term is the lie. This is the relation which the fetus bears to the longitudinal axis of the uterus. The lie may be longitudinal, oblique, or transverse. The presentation is a part of fetus in the which is in over the pelvic brim in relation to the cervix. And when the head occupies the lower segment of uterus, the presentation is termed cephalic, which is the most common presentation. If the head is bed flush on the trunk, the vertex, that is the area between the two parietal bones, anterior and posterior frontally, it will be present. It becomes a presenting part. If the head is fully extended, then there will be the face presentation. And if the head is partially extended, then you get the brow presentation. If the buttock occupies the lower segment, the presentation is termed podalic or the breech presentation. And if the fetus lies obliquely, then the presenting part will become the shoulder. And it's called the shoulder presentation. Any presentation other than the vertex is described as malpresentation. Now there is one more term, attitude, that is flexion or extension. This term refers to the relation of different parts of fetus to one another. Normally, the head, the back, and the limbs of the fetus are quite flexed. In the abnormal position, the head and limbs may be extended. Now, here's the fetal skull before we embark upon this mechanism of labor. As you can see here, the parietal bone is a parietal bone, and the suture between the parietal bone is called this is the parietal suture. Then there is a posterior fontanelle, this is called lambdoid, and the suture is lambdoid suture. Then there is the anterior fontanelle, which is called bragma. It's a diamond-shaped fontanelle, and these are the coronal sutures. Then you have the frontal bone and the frontal sutures, and this is the posterior fontanelle. Now this part basically, this is the vertex part when it comes in the presenting part, and this is the occiput. This is the occipital bone, as you can see more easily in this diagram. The two parietal bones, they form the vertex. This is the most common presentation. And occiput is basically the denominator of the vertex. This is the occipital bone itself. Now here comes the brow presentation. It starts from the anterior fontanelle and ends at the tip of nasal bone. This is called glabella, or you can say supraorbital ridges. So when the head is partially extended, the brow is present. Now this is the face part. It extends from the root of the nose, as you can see, and to the nape of the neck. When the face is extended, then you can get this face presentation. Now let's start. And now here are the few vertical diameters and the transverse and epidiameters of the fetal skull. We should know a bit about them so that we can understand the better position and lie of the fetus. The most common diameter is suboccipitobrachmatic. As you can see, this is a very small diameter. So when there is a vertex presentation, this will be the diameter of engagement. It starts from the suboccipital and goes to the tip of brachma. It consists around 9.5 centimeter. Then when the head is partially deflexed, then it becomes the suboccipitofrontal as the diameter of engagement. Engaging diameter, I must say correctly. It is 10 centimeter. When it is completely deflexed, then you get the occipitofrontal as the engaging diameter of the fetal skull. It is around 11.5 centimeter. And when the head starts extending, then it occupies the diameter like manto-vertical. And here the presentation would be this kind of shape. You can see the shape. It's a brow presentation. This diameter is quite extended, like 14 centimeters. It's a very difficult labor to go through it. And when the head is fully, you can say extended, then you get this submentobrachmatic. Here the face is the presenting part, as you can see. It starts from the nape of the neck and it goes through the brachma. It is 9.5 centimeters. So these are the few diameters that is really important when you go through the labor. Now let's start the mechanism of labor. It refers to the series of physiological changes and movements that occur during childbirth to facilitate the passage of fetus through the birth canal. It involves a series of coordinated movements that allow the baby to move through the pelvis and culminating in the delivery. Now this is just a pictorial representation. It's not of much use here as of now. Now let's put the stages of labor. It is divided into 3 stages. The first stage is dilation stage. From the onset of labor to the full cervical dilatation, that is we say 10 centimeter. The second stage is the expulsion stage, from full dilatation of the cervix to a delivery of the baby. And the third stage is called placental stage, from the delivery of the baby to a delivery of the placenta. Now there are 7 cardinal movements of labor. That of fetus movement has to navigate the birth canal. The first and foremost is engagement. When the widest diameter of presenting part with a well-flexed head, where the transverse diameter of the fetal occiput is a biparietal diameter, as I told you, this is 9.5 centimeter. It enters the maternal pelvis to a level below the plane of pelvic inlet. This is called engagement. On the pelvic examination, the presenting part is at 0 station or at the level of maternal ischial spine. It occurs when the BPD, that is biparietal diameter, it passes through the pelvic rim. In a vertex presentation, the head is usually the first part of fetus to engage. And it signifies that the head is in the correct position to pass through the maternal pelvic inlet. Occurs in most primary gravida women before the onset of labor. However, in the multi-gravida, it occurs with the onset of labor. Position, here the occiput usually in a transverse position. As I already told you, the transverse diameter of inlet is the larger one here. It's around 13 centimeter. And engagement is identified by abdominal palpation method, where the fetal head is 3/5 palpable or maybe less. Now the second is descent. The fetus moves downward into the birth canal. It is caused by uterine contraction, maternal pushing efforts, and the effect of gravity and amniotic fluid pressure. It continues throughout the first and second stage of labor. The fetal head moves downward progressively into the pelvis as the cervix dilates. And the progression is measured by the station relative to the ischial spine, or you can say the head of this is zero station. Now here is the pictorial representation of the descent of fetal head. This head is floating here. It's floating. It's not touching any kind of pelvic bone. When it comes to the 0 position at the level of ischial spine, the head is quite engaged. Now it can't move back. The engagement has happened. You can say the stage is 0. Then it goes descend from +1, +2, +3, and +4 to the outlet. At the +5, the fetus is about to expel. So +4 is at the outlet. Now the flexion. The fetal head flexes so that the chin touches the chest. It's also an MCQ. So this movement occurs due to the pressure of pelvic floor, which throws the fetal head to flex and to touch the chest. Flexion decreases the diameter of fetal head, making it easier for the head to pass through the pelvis. The presenting diameter changes from occipitofrontal, that is 11 centimeter, which was having a partially deflexed head, to suboccipitobregmatic, completely flexed head, that is 9.5 centimeter, for the optimal passage through the pelvis. Flexion of the fetal head allows the smallest diameter, that is the suboccipitobregmatic, of the fetal head to present to the birth canal, aiding in easier passage. Now the internal rotation. By definition, it means the fetal head rotates around 90 degrees in the pelvis. This is required for the head to align with the maternal pelvic axis. In a water presentation, the occiput, that is the back of the head, it moves towards the symphysis pubis, while the face moves towards the sacrum. Significance, it allows the fetal head to align with the widest part of maternal pelvis. It is required because, as we see in the maternal pelvis, the outlet diameter is greater in the anterior posterior. So from the transfer, the head, that is the occiput, has to come in the AP diameter to move out of the pelvis. So this is the importance of internal rotation when the fetal head rotates around 90 degrees to come in the AP diameter. Now the extension, here the fetal head extends as it passes under the pubic symphysis. After the head rotates, the occiput moves underneath the pubic bone and the head extends backward as it emerges out of the pelvis. This extension allows the crowning of the head to pass through the vaginal opening. Occurs due to the upward force extended by the uterine contraction. Now, this is the pictorial representation of this fetal head position at birth by extension. Restitution, it is the visible external movement of the fetal head that corrects the torsion of the neck sustained during the internal rotation. As we memorize it, the internal rotation happens by 90 degrees. So now the neck is in torsion of 90 degrees, and this can't withstand this kind of torsion. So when it comes out, the movement of coming out, it undergoes restitution, opposite movement of internal rotation to around 45 degrees. This allows the hair to come back in line with the shoulder. The occiput points to the maternal thigh corresponding side to which it ordinarily lies. Then the external rotation comes. By definition, the movement of head due to the internal rotation of shoulder as it comes in the anterior-posterior diameter of pelvic outlet. This is visible externally in the direction opposite to internal rotation. To solve it for you, when we are seeing that the head is rotating to 90 degrees to come in AP diameter in the internal rotation, so the torsion is there in the neck. In the same way, the shoulder they still stays in the oblique diameter. They haven't rotated with the head. So when the head comes, it is actually 2 to 45 degrees Celsius, 45 degree. When it comes out of the pelvis, the shoulder is still in the oblique diameter. So to come out of the pelvis, they have to come in AP diameter, which is the largest diameter. For that, they have to rotate by 45 degrees Celsius, 45 degree, I want to say Celsius, 45 degree to come in AP diameter. And this 45 degree movement of shoulder, it combines with the external rotation of 45 degree of the head. And this shows us, this is the physical direction of the opposite to internal rotation. So now the shoulders are lying in the AP diameter so that they can easily come out of the pelvis. And this is visible externally as the external rotation of the head, again with the 45 degree. Now the expulsion happens. Here the shoulders and the rest of the body are delivered. The anterior shoulder usually emerges first, followed by the posterior shoulder and the rest of the body. This stage involves the final expansion of the fetus from the birth canal. Here the mechanism of labor, basically the 7 cardinal rotation is done. Now I can show you in the picture. This is the 45 degree rotation of the occiput only. And this is the rest of the 45 degree rotation of the axis or the head to complete this external rotation. Now here is just a short description of the cardinal movement along with the station of the head. When the engagement happened, the head was at 0 station. It reaches the level of ischial spine of the pelvic inlet. Descent, the first stage, here the navigation of the head is happening from 0 to +2, +3, +4. Everything is counted as a descent. Fetal head moves through the pelvic inlet and to the cervix. In the internal rotation, it happens from the station 0 to +2. Here the fetal head rotates 90 degrees to align with the maternal pelvis. AP diameter. Extension, station +3 to +4. The fetal head extends as it passes under the pubic symphysis and the crown. External rotation, which includes the restitution, it happens at the +5 station. The head rotates to align with the shoulders, indicating the imminent delivery. And the expulsion, the anterior shoulders are delivered here, followed by the posterior shoulder. Now here are some key points to remember for the Neet PG. Presentation and position. Most deliveries occur with the vertex presentation, head first, but breech or shoulder presentation may occur in some cases and requiring a different mechanism. Then the type of pelvis I already told you, the gynecoid, android, and anthropoid and platyploid. The most common and most favorable is gynecoid. Android basically having a difficult labor, and anthropoid and platyploid, it can present as a deep transfer arrest or even the rest of the labor. So you need to go for cesarean section. Now there are the factors affecting the labor. Power, they are called 4 P's: power, passage, passenger, and psyche. The power means uterine contraction and maternal pushing. The passage, the pelvis, and the birth canal. The passenger is fetus, its position, lie, and presentation. And psyche, the maternal emotional state which can influence the labor progresses as well. Then the abnormality in the mechanism, it could be malposition. It means the occipital-posterior position can delay or complicate labor due to difficulty in the internal rotation of the fetal head. Malpresentation, when there is something other than the vertex, like breech or transverse lie, and they basically require a cesarean section nowadays. Now, here is a mnemonic for cardinal movements to remember. Every damn fool in Egypt eats egg. E for engagement, then descent, then the flexion, internal rotation, extension, external rotation, and last the expulsion. Now here are the three MCQs to discuss with you. Now first is, which of the following is the correct sequence of cardinal movements of the labor? This is the most common thing. Engagement, descent, flexion, the internal rotation, then the external rotation, and then the expulsion. Next is, the first movement of fetal head in labor is engagement. The mechanism of labor requires the fetal head to move into the pelvis in which position? It's a vertex position basically. In the vertex position only we can have the normal labor. In the breech and the transverse, we don't have the labor as such. Then the internal rotation of the fetal head occurs in labor to align the fetal head with the maternal pelvic axis. It can't be allowed the flexion of the head, because for the flexion of the head you have the pressure of the uterine forces, and the facilitate descent of the shoulder is again the pressure and this you can say the gravity that acts in this. So the most appropriate answer is to align the fetal head with the maternal pelvic axis. Then the fetal head is delivered by which movement? It's extension. Which of the following is the last cardinal movement of the fetal body during labor? Well, it is the expulsion. In which stage of labor does the fetal head rotate 90 degrees to align with the maternal pelvis? Internal rotation. The process of external rotation of the fetal head after delivery is also known as restitution. Basically, restitution and external rotation are one and the same thing, but there is a bit different when you go into depth. But here the answer is restitution. The initial descent of the fetus begins during which stage of labor? During the first stage. Basically, descent start even before the onset of the labor. So we can say first stage, the initial descent. Which of the following movement helps in reducing the diameter of fetal head during the labor? It's a flexion, which gives us the best, shortest diameter, that is the sub-occipital-brachmatic diameter to come in the engagement. The fetal head flexes when it encounters the pelvic floor in order to decrease the diameter of fetal head. Now, which of the following statement is true regarding the engagement of fetal head? It occurs when the BPD, that is the biparietal diameter of the head, it passes through the pelvic inlet. This is the, you can say the BPD diameter is the only diameter which takes the engagement of the fetal head. This is the transverse diameter. We're not talking about the anteroposterior here. Anteroposterior diameter can be suboccipital-brachmatic, suboccipital-frontal, or anything. But the transverse diameter is always the BPD, that is the biparietal diameter of the fetal head during the engagement. Now, a common complication of labor is the arrest or descent of fetal head. Which factor is most likely to contribute to this? It could be normal pelvic size and shape. No, it won't lead to the arrest. Occipital-posterior position, intact membrane, uterine contraction. So, occipital-posterior position usually lead to the arrest or the descent of the fetal head due to the malpresentation, you can say that. Now, in a normal labor, the fetal head rotates externally too, align with the shoulder of the delivery. As I already told you, they move. The shoulders come in AP diameter from the oblique, and it is visible externally as the fetal head rotates external rotation. So the answer is align with the shoulders for delivery. Now, which diameter of the fetal head engages in a well-flexed vertex presentation? It is a suboccipital-brachmatic. In normal labor, internal rotation of fetal head occurs to align with which diameter of the pelvis? It is the AP diameter. Because the AP diameter is the largest diameter of the outlet, so it has to come in AP diameter to come out of the pelvis. Now, what is the main purpose of flexion during the mechanism of labor? To reduce the diameter of presenting part, as we already discussed. At what stage of the mechanism of labor does the fetal head deliver? During the extension. It's a repeat question. Now, restitution refers to which of the following? It's a realignment of the fetal head after delivery with the shoulder, a rotation of the fetal head to the anteroposterior diameter, or descent or external rotation of the shoulder? Well, it's a realignment of the fetal head after delivery with the shoulder. Now, which of the following occurs last in the mechanism of labor is expression. Which of the following indicates successful engagement in labor? It is biparietal diameter passes through the pelvic inlet. It indicates the successful engagement of the labor. Now, what is the most common position of fetal head during engagement in normal delivery? It is the occipital transfers. It is the most common position of fetal head when the engagement happens. Now, the 7 cardinal movements of the labor, it refers to the changes in position of which body part of fetus? The shoulder, feet, head, or legs? The answer is C, head. In which of the 7 cardinal movements of labor does the chin of fetus tuck into the chest? Is the flexion, when the chin of the fetus is stuck into the chest to reduce the diameter of the head. Now, which of the 7 cardinal movements of labor can happen even before the labor begins? Now, it is basically engagement, external rotation, or the flexion or the descent. It's basically a descent which is even happening before even the labor begins. Engagement happens, or even the answer is in the engagement, because in the primary gravida, engagement even happens before the labor begins. So answer is A here. So here I end this presentation. Thank you, sir. Hello.
Just a moment, ma'am. I will just finish the. I'll pause the recording.
Okay.
Stop. Pause.